Well, thank you, Jenny and Greg, for the opportunity to talk today. This is some really exciting times in the world of myeloma. And, I think no one wants to ever have myeloma, but to have these amazing treatments coming through, multiple ones throughout every year is huge. And we're learning so much and it's sort of exponential. And I think Alex just did a fantastic job of really giving you the science of these new therapies that are coming out and kind of scientifically, why we think they work and how hopefully we can make them better in the future. What I'll do, I have about 12 slides. The first 10 are probably introduction, just to kind of put everything into the bigger picture. And the last 2 slides are really where I'll spend the most time about how do we apply this. So right now, what do we do for our patients in treatment and combining treatments, and which order do we go in, and what are we thinking when we do that? And then for the future, how do we think we're going to make it better? How can we potentially cure patients, and how do we combine these things to go in the right direction? I think, as Jenny said previously, different doctors do different things, but as long as there's a rationale and it makes sense, really that's what we want to do and make sure that everybody gets the right treatment. Every patient's different, so you can't do the same thing for every patient, but really learning more and more of these biomarkers and toxicities that different people have, that really helps you pick that right choice to go forward with. And so for mine, the overview is treatment strategy, timing of treatment, and then complementary targets is what we'll talk about. So treatment strategy, of course, just putting in perspective, for our patients, when I can't cure most of my patients for myeloma, the optimal treatment goals, what are they? When I talk to my patients, this is what we talk about. We want a deep response. We know that patients who get those deeper responses end up, having better progression-free survival, or hibernation periods, as I call it. And now we know that patients who get MRD undetectable disease do even better. So these are sort of the biomarkers that we can use with these new therapies that are coming out, saying, okay, which patients get to that MRD status? How can we get everybody else to that MRD status so they get that longer progression-free survival and then survival? And the goal is we want to achieve long-term survival. As Alex showed, those curves are getting better and better, and we want to keep making them go higher. And in the meantime, we want to preserve good quality of life. So no matter what we find scientifically, we have to make sure that it actually doesn't have crazy toxicities, things that we can, really take care of. And then, of course, delay disease progression and resistance. And what I mean by this is resistance. When we're treating patients with different therapies, we want to make sure we don't make that myeloma smarter. So there's a timing of when you need to treat something versus when you watch. Because if I treat too soon, I actually might make you more resistant, your disease more resistant, sooner than we need it to be. So there's a lot of, science and art of medicine here. And so choosing the right treatment, does timing matter? And once again, our goal here is to spread these out. We want the remission times to be longer and longer between these different lines of therapy, and we want survival to be better. And so timing does matter. The biggest thing is we don't want to miss disease progression. So these are all the different things we look at for patients who have blood tests or protein in their urine, or they only have light chain disease, or I think one of our patients in the chat said they have non-secretory disease, so they don't have blood tests we can follow. So we have these rules, but really, for each patient, it's making sure we're treating at the right time. And these are the different categories of patients I usually have. Some are asymptomatic and they have a biochemical relapse with just numbers, but they're doing so well that I might just watch them on if they're on observation, or if they're on minimal therapy like maintenance, and we just keep an eye on it. Then I have patients who are high risk disease, and they have rapid doubling time. That's a different group of patients that I'm going to start treatment pretty quickly on. And then when we get into the red, when patients have symptomatic disease relapse or extramedullary disease, I should have started treatment yesterday type thing. So there's different categories of when these treatments are, and that helps us decide which treatments we actually pick. And I won't go over this too much, but in terms of timing of treatment, all of these different variables that we're looking at, patient-related, disease-related, treatment-related, they actually change over time. So, every time my patient comes in and I have to think of a new therapy, we sort of, think about all of these factors again. So then coming more to the crux of the talk, complementary therapies. I mean, myeloma, we do combination therapies, and it's because can't knock it down usually with just one drug. It becomes smart a lot faster, and it learns to become resistant. And so we pick different ways and different mechanisms of action to kill that myeloma. And that's why we do the combination therapies. And sort of, this top line are drugs that we've had for a few years now. So the proteasome inhibitors, the immunomodulatory drugs that are sort of, work as immune therapies, partly by activating your T cells and NK cells. And then, of course, the monoclonal antibodies that Dr. Luskin talked about, the CD38 and SLIME-F7. And then we have some other drugs that have come out recently. The BCMA targeted drugs, of course, the first one is belantamab, the ADC. And then we have melphalan flufenamide, which works very differently, but uses an old school drug, melphalan, but has a new way of getting it to the cell, which I'll talk a little bit about. And then, of course, the CAR Ts. And so with these newer therapies, what are these older therapies doing that affect the outcomes of these newer therapies? And do we change something in here that would make these work better? Or can we combine these with some of these to make those, responses and outcomes better? And really, that's what I think is so exciting about the future. And, there's a lot of different things we think about when we're deciding to combine therapies, but really the biggest ones, of course, are the mechanism of action. When I pick different drugs to put together for a clinical trial or for my patients, really, does it make sense that they work? Preclinically, that's what we do. We do these things in the lab and in vivo studies, and then we do phase 1 studies, and then we do phase 2 and 3 studies to finally get the approvals of these drugs that you just saw the last slide. Those are all approved drugs. And sometimes we're a little bit surprised by we wouldn't think that the mechanism of action would really work together, but they do when we do the clinical trial. So there's a little bit of, I would say, magic in that too, not just all science, but really it's coming up with the best way to kill that myeloma cell with the least toxicity, right? So the other problem is toxicity profile. We really don't want to cause, extra issues, right? The goal is to knock that myeloma down without causing that toxicity. So these are the two main things we look at when we're thinking about combining therapies to make it better. And so Dr. Luskin already talked about the ide-cel CAR T, the design, but really what I wanted to talk a little bit more about is this is, one of many CAR Ts that have been looked at in myeloma, but obviously the one we had the most data for and a fantastic response rate. And this was done in patients, an average of 6 lines of therapy. So they've had pretty much all those other therapies we just talked about, and then they're getting this. And to have a 70 to 85%, 84% response rate at the highest, the dose level that we think is the best, that's never happened before. And so we found something here that really is different, right, than any of the other therapies. And so the other thing I really want to talk about, though, is biologics. So the first therapies, going back to this, these first therapies are sort of more chemotherapy and indirectly are immunomodulatory, but not so much biologics. Now, as we go into cell therapy and even the monoclonal antibodies, there's a lot of other things that really help us decide if something's going to work or not. And we don't know the answers yet, but patients' T cells, these are your own T cells that we're taking out and putting a receptor in. So does your T cell health matter? Does the treatment you had right before we collected your T cells matter? The antigen itself. So BCMA, I think we've gone over in a lot of detail, so I won't talk too much about that, but how much BCMA do you need on a plasma cell for any of these different therapies to work? So for a CAR T, we think we probably need less BCMA. You don't need as many molecules on your myeloma cell versus maybe for some of the other drugs like for the ADC, the antibody drug conjugate, maybe you need a little bit more for that enough drug to get into the cell. So that mechanism of action really matters here. And what happens to BCMA when you give different therapies? So, in terms of what my questions really are for future combinations, we know that IMiDs and, these drugs, CELMoDs that are also in research right now, they work as chemotherapy partly, but they also do improve T cell health and activate T cells. So would a combination with CAR T cells, for instance, and CELMoDs and IMiDs be something worthwhile? I think the biggest thing for CAR T right now is that it's a one-time infusion and you're done. And my patients love the fact that they have this chemo-free period, especially when they have relapse refractory disease. And it's one of the best things ever. But, if we did something like a maintenance, maybe for a few months, would it actually improve those T cells where they live longer in the body so they can, maybe monitor for the myeloma longer to keep it down. Don't know the exact answer, but those are sort of the thoughts that we have that maybe would improve even based on the outcomes we've had so far. Then there's something called gamma secretase inhibitors. BCMA is shed off, it gets shed off the myeloma cell. And we know that patients who are smoldering have less BCMA. They still have it, but it's usually less than when you're relapse refractory. There's a lot more soluble. And gamma secretase inhibitors basically keep that BCMA antigen on that myeloma cell. So you're not shedding as much of it into your blood. So if it's on the cell, hopefully that means the CAR Ts will actually get to the myeloma cell in a much better way and maybe not get stuck in the blood. There's no data yet that says that soluble BCMA affects the ability for the CAR T to work. But, theoretically, if more of it's on the cell, we would hope that more myeloma cells get killed off or maybe get killed off faster and more of these CAR T cells survive. So the other part of CAR T cells is that when the T cell actually kills that myeloma cell, it releases all these cytokines and that actually has more cells come there and it creates more CAR T cells that hopefully then live longer to keep an eye on that myeloma, right? So this is that biologic part, that there's a lot more going on than just, hey, we got a drug, we kill that myeloma and, then we have to keep giving it. So there's a lot to learn because of that, but I think that's why we're seeing such fantastic responses. Cytokines. So, we talked about there's different parts of this CAR T, right? So we have this 41BB here is a co-stimulatory molecule, which actually just sort of gives it a little fire under it. So once the CAR T cell starts working, it kind of helps make it expand and create more T cells and really kill and activate and kill the myeloma. And then there's things like cytokines in our own body that help. So we have IL-2 and other things that we can measure that kind of go up that help all these immune cells keep doing what they're doing, keep fighting. And so what if we give a cytokine with these, CAR Ts to make them better? Same thing with radiation. I think there's some patients where radiation actually helps create more T cells that we already have in our body that were helping fight, against the myeloma before. That once you have cytokines from the CAR T kind of, acting a little bit crazy and you do radiation, you actually see a better response from your other T cells coming in and helping fight the myeloma. So these are, some pretty interesting papers that are out there. I think this one was actually from Sloan Kettering. And so there was a patient that radiation helped actually improve responses once they got CAR T. Another big question, in complementary antigens or flags on the myeloma is DARA. So daratumumab goes after CD38, which, like BCMA, is on good and bad plasma cells, right? It's on the myeloma cells and it's on the good plasma cells that we have. DARA or CD38 is also on certain T cells and certain NK cells in our body. For the most part, we think that it's on the type of T cells that regulate our immunity and kind of help knock it down. And so we would want those to go down when we give CAR T, so they're not there policing the CAR T, right? But there's also thought that maybe these are on some of the good T cells that we want to be active. And if we are killing those off, maybe it's not good to have DARA on board. I personally don't believe that, but there is definitely theories out there that maybe we should be avoiding DARA right before CAR T or giving some of a washout period. Once again, these are all thoughts, but things that, clinically, hopefully with more and more data, we'll be able to really say yes or no. And so the question would be, can we give DARA as more of a lymphodepleting part of the therapy instead of giving it before we, let's say, collect the apheresis cells for the CAR T? Because that product that we get from when we collect those T cells, really, we want that to be the best cells. So there's thought that maybe using IMiDs, for instance, right before apheresis would actually improve your T cells. So when we collect them and we make the T cells, then maybe it'll make better CAR Ts. Don't have data, but these are all the things that we'll learn as now we have a standard of care and people are going to look at this. One of the big ones is alkylators. So should alkylators, so these are drugs, like chemo drugs, Cytoxan, melphalan, bendamustine, which we don't use as much, but there is some myeloma therapy that uses this. When should we use this? For the most part, in the lymphoma world and some studies in the myeloma side, we think that alkylators really cause
damage to your lymphocytes, to your own T cells and NK cells. So we try not to use them. If we can, we try not to use them right before we collect your, your cells for apheresis for CAR T, because it might make it harder to make your cells, or maybe they won't, the quality might not be as good. So that's one thing that we try. Um, try to avoid if we can, at least right before. And remember, these are the drugs that we use for lymphodepletion prior to giving the T cells. So toxicity wise, we also don't want to cause too much myelosuppression. So your white count being too low, or your platelets getting too low right before we try to give the CAR Ts, which can then cause other, side effects. And so that's one of the reasons we try to avoid it, right before apheresis at least. And I think the biggest and kind of the most exciting part for me is how are we going to combine all of these, right? So if we can combine different therapies, well, what if we have different antigens that we can go after on that myeloma cell? So in terms of mechanisms of resistance for BCMA CAR T, there's been some data that shows that maybe you get BCMA loss, but for the majority of patients, we don't see that. We do see some BCMA dimming, which can come back up for some patients. But really, we think a lot of it could be related to the T cell itself, and if it doesn't persist. Not 100% sure, but possibly. So what if we, have different ways of doing this? So if we think it's the antigen, can we do different antigens? Can we attack it not just by BCMA, but by some of the other antigens Dr. Lisogin talked about, and also CS1, SIMF7. I will be presenting one of our allo CAR Ts for CS1, some of the translational data in a month. And so after that, I'll be able to talk a little bit more about it. But, it's a different antigen, but that antigen is on other cells and it can cause some other side effects. And so really to find the perfect antigen that we can, attack at the same time might take a little bit of time, but definitely things that we're working on over the next couple of years. And then the other question is, if not multiple CAR Ts, because that might create too much, let's say, side effects. Maybe it'll increase cytokine release syndrome. Not sure, but if it does, what if we do something like a CAR T and then give a bispecific afterwards, right? So bispecific takes that T cell on one hand, it handcuffs it, takes the myeloma on the other hand, handcuffs it, and puts them next to each other. If you have a CAR T that's already more zooped up, ready to kill that myeloma, and all this is doing is create even more killing for that myeloma and kill more of those myeloma cells that can then lead to better outcomes. So, for CAR T, this is sort of where the antigen, the mechanism of action, the other drugs we use, all of the timing of when we do this really, really matters. And I think we'll be learning a lot more really quickly in the next, 6 months to a year about what all this means. And then just to shift a little bit, since you guys are going to talk about this new drug that just got approved as well, and just mechanism of action type, discussion. This is melflufen, so melphalan flufenamide, sorry. So this is something you guys are going to talk about, I think, next time. But really, this really is a old drug, melphalan, that's an alkylator, but just it's targeted, right? It's getting that drug to the myeloma cell without creating, side effects that normal melphalan does. And so here, they've actually compared it to the antibody drug conjugate, using the same type of idea, but it's not an antibody that we're using. Now we're using just the structure of the cytotoxic payload, which is the melphalan, with this peptide carrier. And what the peptide carrier does is it's lipophilic. And so it can just actually cross that cell membrane really quickly into cells that have a lot of aminopeptidases. And myeloma does, and cancers in general do. So that's really how it targets the myeloma cells. And once it gets in here, those aminopeptidases cleave that payload off, the melphalan off of the peptide carrier. And now you have the melphalan that's already in the cell, and it works like an alkylator. It breaks DNA, and when the cell tries to divide, it kills it. And so it's really using an old drug, but decreasing the toxicity and figuring out a better way of getting it to the myeloma cell. And so here, I think, what do you combine it with? So it's been approved as, with Dex, and really the other studies that they're doing, this is a little bit small, but there's lots of studies they're looking at. And I think one of them is with bortezomib, which makes sense. We do alkylators and proteasome inhibitors. And the other one is with DARA. And so, an immune therapy with an alkylator, a lot of people thought it wouldn't work, but we have studies like DARA VMP, where melphalan and DARA worked for patients. So, this is something else we'll learn a lot about. Maybe drugs that we didn't think would work well together actually do when it comes to patients. And so, just really exciting times in general. And so with that, I will actually stop and hopefully we can go to the question and answer.